Today topic of discussion, bronchiectasis. What is bronchiectasis? It is a abnormal and permanent dilatation of bronchi and bronchioles. So abnormal and permanent dilatation of bronchi and bronchioles. Why are these bronchi and bronchioles dilated? That's because of destruction of smooth muscles and elastic tissue of the bronchi and bronchioles. And why are these destroyed? That due to persistent or severe infection of the respiratory tract. So abnormal and permanent dilatation of bronchi and bronchioles name is called bronchiectasis. So this one is caused by destruction of smooth muscles and elastic tissue. Smooth muscles and elastic tissue due to persistent or severe infections. Nowadays it is quite and uncommon, not because of better control of infection. Then what are the risk factors which predispose to the development of bronchiectasis? What are those risk factors? The most common risk factor. The risk factor can be classified under various categories. The most common one being congenital or hereditary condition which predispose to chronic infection. What are these conditions? They can be cystic fibrosis. It would be intralobular sequestration of the lungs. Intralobular sequestration of the lungs. It would be various immunodeficiency state. It would be primary ciliary dyskinesia, then carcinogener syndrome. So because of congenital or hereditary conditions, what are the things? Example here, cystic fibrosis, intralobular sequestration of the lungs, various immunodeficiency state, then primary ciliary dyskinesia, carcinogener syndrome. So what really happen in all these conditions is that there will be impaired mucociliary clearance mechanism. There will be impaired mucociliary clearance mechanism, and the defense mechanism is lost in the form of improper secretion of mucus. So here what will happen that this impaired mucociliary clearance mechanism and defense mechanism is lost in improper secretion of mucus, and all those things predispose to the development of chronic or recurrent infection. The second risk factor being severe necrotizing pneumonias, and these necrotizing pneumonia can be bacterial, viral, even fungal infection. So whatever it is, the necrotizing infection severe as a risk factor for development of bronchiectasis. Bronchial obstruction can be the risk factor for the development of bronchiectasis. The obstruction would be because of tumor, or would be foreign bodies, or because of impaction of that mucus. It would be because of immune disorder like It would be because of rheumatoid arthritis due to systemic lupus erythematosus, then inflammatory bowel disease, and various graft versus host disease. So these are the various factors which are associated with the bronchiectasis. There is another risk factor which is idiopathic. We don't find any causes, that one that account to around 50% cases of bronchiectasis. Next, what is the pathogenesis of bronchiectasis? Two most common things are obstruction and infection. So what really happens when there is an obstruction? That obstruction would lead to impairment of mucociliary clearance. Mucociliary clearance that result in pooling of secretion distal to the obstruction, and because of pooling of secretion distal to the obstruction, which further leads to the development of inflammation, and this inflammation can be due to infection. This inflammation can be due to this infection. This infection is due to either bacterial, viral or fungal. So here inflammation is due to infection. This infection is due to bacterial, viral and fungal infection. When there is an inflammation, that inflammation leads to destruction of bronchial wall, particularly the smooth muscles of bronchial wall and elastic tissue. So once this elastic tissue is destroyed, what happens is there is weakening of wall of that bronchi and bronchioles, that causes of dilatation. So once there is weakening of wall of bronchi and bronchioles, that is cause of dilatation. So obstruction or infection which can lead to destruction of bronchial wall because of inflammation leading to weakening and then dilatation of that bronchi and bronchioles. So that is the pathogenic mechanism of bronchiectasis. Then what are the clinical features? The most common presentation of bronchiectasis is severe persistent cough. Severe persistent cough with expectoration of bowel smelling sputum. Then dyspnea and orthopnea in severe cases. Occasionally there would be life-threatening hemoptysis in the process of destruction of bronchi and bronchioles. Then even the adjacent blood vessels can also destroyed. So this destroyed blood vessels can have access to bronchi, where the patient manifest with this hemoptysis. Because long-standing persistent infection, these patients are almost always having fever. So there would be systemic, because of fever, this one systemic febrile reaction. And what is important to note that manifestation are often episodic and are precipitated by upper respiratory tract infection. There would be paroxysms of cough are particularly frequent in that morning when the patient rise. Why that happen? That's because the whole night secretion are pulled. When that patient rises suddenly, these pool secretion will gain access to bronchi and bronchioles that result in paroxysm, basically to remove that or expel that, put them outside. The patient will have continuous off with sputum production. Next one is cross morphological pictures crossly. It is the characteristically the Bronchiectasis is distal bronchi and bronchioles beyond the segmental bronchi. It involved either in that segment or diffusion. Most commonly bilateral lower lobe are involved. So most commonly bilateral lower lobe involvement. So it involves lungs either in that segment or diffusely. Most commonly bilateral lobe are involved. Flora is usually fibrotic because of long-standing infection leading to fibrotic reaction. It would be thickened with addition to chest wall. On the cut surface of the lungs, the dilated bronchi appear cystic and they are filled with mucofluent secretion. Because of the cystic nature of the dilated bronchi in the lower lobe, this appearance is referred to honeycomb appearance. Honeycomb appearance seen in bronchiectasis. Another important feature of bronchiectasis is how these bronchi and bronchioles are dilated, and that comes to understanding the Reed subclassification of bronchiectasis. Dr. Reed was renowned pathologist. She was a senior assistant when she was working in Australian medical school. She found out that pathological feature of lungs in bronchiectasis patient. When she subdivides based on the type of dilatation of bronchi and bronchioles into this category. This one is the normal bronchi. It is branches if there is uniform dilatation. She call it as cylindrical type of bronchiectasis. If there is irregular dilatation is called as varicose type of bronchiectasis. Then if very large, cystic or circular, it is referred to cystic bronchiectasis. So remember here this morphological classification of bronchiectasis proposed by Dr. Reed. This is Reed subclassification of bronchiectasis. Circular or cystic. Next, moving to that morphology microscopically, the bronchial epithelium, it can be normal. If that inflammation is not there or infection is less, it would be ulcerated. If it is acute inflammation or because of chronic inflammation, it might show squamous metaplasia changes. Bronchial epithelium may be normal. Ulcerated only shows that metaplasia. The wall of bronchi and bronchioles shows infiltration by acute or chronic inflammatory cells depending upon the type of inflammation. Whenever there is acute or chronic, then necrosis is often evident, which is the one which destroys that bronchial and bronchiolar wall. And sometimes you know that necrotic parenchyma is so much so that can be form abscess with co-resistant infection. Fibrosis of bronchial and bronchiolar wall occur in long-standing case and peribronchiolar fibrosis developing more chronic cases. Next, the common causing infection by bronchiectasis are Haemophilus influenza and Pseudomonas aeruginosa commonly causing infection. Haemophilus influenza constituting around 50% of the cases. Pseudomonas aeruginosa constituting about 12 to 30% of the cases. The rest of the cases would be non-tuberculous mycobacteria. It would be Moraxella, then Staphylococcus aureus, Streptococcus pneumoniae, Klebsiella species. Then how do you diagnose bronchiectasis? Almost always it is based on the clinical history and sputum examination. Chest X-ray would lead you to that diagnosis, and high resolution CT scan is very much important, is required for confirmation of bronchiectasis. Chest X-ray, you can find out that increased bronchiovascular marking, honeycombing can be observed in severe cases. And this lung resolution CT scan confirm the binding of chest X-ray. Next, how to treat that patient because most of the patient can still be smokers if they are smoking. You have to ask them to stop smoking. That main treatment involves medical and supportive therapy. Surgical treatment play a major role, and it play a role only when that bronchiectasis is localized and limited and having these complications. Mainstay of the treatment medical and supportive therapy, where you have to treat with antibiotic to clear up that pulmonary infection. Bronchodilator, again through that bronchi are dilated in bronchiectasis. As yet, bronchodilator are used to clear airway basically because there will be obstruction because of mucus infection, or would be something else. Oxygen supplementation is necessary if that patient is hypoxemic, and of course if severe hospitalization is important for controlling infection. The complication would be that infection can extend and form lung abscess. In that long standing case, the fibrosis can be predominantly in pulmonary fibrosis, and that pulmonary fibrosis can result in pulmonary hypertension, resulting in chronic or pulmonary, leading to right side heart failure, and all the chronic inflammation and persistent inflammation can result in reactive systemic amyloidosis. In this video discussed bronchiectasis. What are the risk factors? First one is congenital or hereditary condition, then necrotizing pneumonia, bronchial obstruction, immune disorder, and then other idiopathic 50% cases, then pathogenesis because of obstruction and infection. This one leads to dilatation. Then clinical features, what are the signs and symptoms, then cross, how it is present, then microscopic, one more things, red subclassification, then morphology of microscopy, then what are the common infection, how to diagnosis, then what are the treatment and complication. Thanks for watching.